humble. He asked me, and Bruce is so humble. He asked me to keep down his introduction to one sentence, but I can't do that because Bruce is so worthy of such a great introduction. Who we have with us tonight, this is Bruce Perkins. He's an endocrinologist, he's a clinical scientist, and so much more at the Facility of Medicine at the University of Toronto. He holds the Sam and Judy Pencer Family Chair in Diabetes Clinical Research and directs the Leadership I apologize, Center for
Sinai.
Diabetes. His research platform, research leadership, clinical practice, and advocacy work has focused entirely on strategies to improve the life of those, like himself, with type 1 diabetes. Using cohort and trial methods, his research has focused on early biomarkers and mechanisms of diabetes complications and complications too, complication prevention through artificial pancreas technologies, add on to insulin drug therapies, as well as other researches in cell-based therapies. He is a vice chair of the Executive Historic DCCT/EDIC study and co-leads the Innovations in Type 1 Diabetes Global Group within the Diabetes Action Canada, a national patient-oriented research strategy. So, and he also has been awarded the Canadian Diabetes Association CIHR Young Scientist Award and the Gerald Wong Service Award from Diabetes Canada for his research and advocacy. Thank you, Bruce, for being here. And what an incredible, incredible resume.
Thanks so much, BJ. Actually, Victoria was asking who you are. You should introduce yourself.
Me? Oh my
Yeah.
goodness. No way. But I will just give a brief introduction. My name is BJ Garso. You may follow me on social media or met with me in person at many of the Connected Motion camps here in the States. I am a type 1 diabetic of 31 years. I am also the first female MMA type 1 diabetic fighter in the United States. And I've had 5 fights, which all money went back to type 1 diabetes research and all kinds of wonderful stuff. And yeah, so just a little bit about me. I've been active in Connected Motion since 2016 and absolutely love this organization in person as well as our online events. So thank you, everybody, for being here.
Well, now that I know about your story, I don't want to talk. You should talk for this this 90 minutes, but you can schedule it for the next one. Or maybe you've already talked about your experience as an MMA fighter. I have some slides. So let me share. Oh, I hope you all see this. Can you see this?
Looks good.
Okay, perfect. So Victoria and Jen asked me to speak around what's next in type 1 diabetes with a particular focus on this concept of screening for diabetes before people get diabetes. That sounded weird, but they're right. It's an unbelievable kind of paradigm shift in type 1 diabetes that I feel like us as people living with type 1 diabetes should know about. And I was also asked to speak a bit about cell-based therapies that are intended to cure type 1. There's amazing movement in that area that I'd like to share with you kind of briefly. And I threw in a few other random things, but mostly what I want to do is make sure I don't spend too much time talking, that we have some time for you to ask your own questions. So at the end of this, let's say, I think I'll speak for about 30 to 40 minutes max. But by the end of that, I'm hoping you'll have learned first, how type 1 can be identified before symptoms start, what new treatments may help those that we identify to delay or maybe even prevent type 1 diabetes, what cell-based therapies are and how close they are to becoming available for us and people with type 1 diabetes in particular situations. And I'm hoping that you'll have a chance to ask any questions you have about research and new treatments or anything at all. Like I'm just happy to talk anything. I eat, live, and breathe type 1 diabetes, so I'm thrilled to talk about it. And as you've heard, my research in this area is fairly broad within type 1, which is usually considered not a good key of success in the research world. You should be like pinpoint focused on one thing, but I was never gratified with that. So that's how it is. Let me start with this, a context, particularly for Ryan and BJ who are in the US, because all Canadians just innately know this story. This is Frederick Banting in the middle and his student Charles Best. They were the core members of the team that discovered insulin just over there outside of my office. And that was just over 100 years ago. And at that time, if someone was diagnosed with type 1 diabetes, they generally survived for a few weeks or a few months, to be honest, and then would die of diabetic ketoacidosis. Without insulin, insulin was the life-saving thing. People could not survive. But it turned diabetes into a condition where people survived, but then we learned about complications. And, there's been unbelievable innovations in type 1 diabetes management in the last 100 years. But, even though so I'm trying to move my face out of the way and I can't. Even though there have been these amazing innovations, Banting and Best would be fairly discouraged if they were to come to modern times and see how things are going. They'd have to realize that a lot of us with type 1 feel isolated. That's a reality. That we fear hypoglycemia, some of us paralytically so. That we fear long-term complications, some of those complications, like foot complications, more than death itself. That we carry a huge day-to-day self-management burden. And at the end of the day, it's actually a pretty small proportion of us who meet the evidence-based targets for blood sugar control with A1C, the targets that have been proven to lead to the lowest possible risk of long-term complications. So those are problems. However, they would be very encouraged by some outstanding advancements that we've seen in the currently are seeing, or even in the last decade. We're really in an outstanding new era in type 1 diabetes care. I feel like I'm very, very lucky to be being in clinical practice now. We have a lot of very cool things that we can help to alleviate some of those gaps that I just talked about. So first of all, we have, for the last decade, actually automated insulin delivery, just more than a decade if you count open source do-it-yourself systems. And these have vastly improved over the last decade. This allows us to automate aspects of our insulin. We also call it hybrid closed loop because it automates basal and to some degree correction insulin, but it doesn't automate our food insulin, nor does it automate our blood sugars over exercise. We have to tell it about food and we have to tell it about exercise, but an amazing advancement. And I'm not going to talk very much about this today. That's about it. We also have drugs that primarily are drugs that have been transformative in type 2 diabetes, and there have been aggressive research programs to see if they could help people with type 1. Like if they're so damn effective in people with type 2, why not test adding them on to insulin in people with type 1 diabetes? And there's been huge movements in this field, very interesting things that are meeting some of the other problems related to type 1 diabetes that we didn't recognize until fairly recently. A lot of these were recognizing by studying that DCCT EDIC cohort, which was a group of 1,400 people who were in a trial in the 80s. They're responsible for how we manage diabetes today, the concept of intensive insulin. But we've been studying those 1,400 people now for over 45 years, and we've learned a lot of new things. And some adjunct to insulin or add-on to insulin therapies may help with those. There's even guidances here. This is just to remind me that, a bunch of international experts have done a consensus report on the GLP-1 receptor agonist-like drugs. Those are the drugs like Ozempic, that when you add them to automated insulin delivery, they can really help with blood sugar control. In Canada and the US, these are not approved for type 1 specifically, but there's more of an openness for physicians because of guidelines like Diabetes Canada that say that we should have shared decision-making and open conversations about these options for people who may need them. And also we're learning from registries, like in Canada, the Better Registry, that people are more and more adopting these add-on therapies. But I'll leave that as well. I will end by talking about stem cell-derived islet transplantation, which is unbelievable. And so I look forward to explaining that. Here they've been looking at the Edmonton protocol where they take donated islet cells and infuse them into the liver, but finding other sources from stem cells. And, we took on a study in here at UHN Sinai, and the patients that we brought into this have been insulin free, and I'll talk to you about them at the end. But there's also this other amazing thing, and that is the ability to predict people who are at risk of later developing type 1 diabetes and putting immune modulation therapies to prevent the progression or delay the progression. So I'm going to focus mostly on that to start with. Let me start with, actually, I'm sorry, I'm just going to open a drink here. I'm so thirsty. Some key points about type 1 diabetes in Canada, and actually these apply to the US, and prevention as well. So it turns out in Canada, we have nearly 300,000 people with type 1 diabetes. If we look at the incidence rate, like it's a fairly uncommon condition. There's about 30 people out of every 100,000 each year who develop type 1 diabetes. And you can see by those incidence curves over these decades, for some reason, it's increasing a little bit year by year. But if we take the population of Canada and look at the incidence in Canada, we kind of expect nearly 12,000 new cases per year. So that means there's 12,000 people out there who this year don't have diabetes, but next year will. And wouldn't it be amazing if we could identify who they are and try and delay or stop that diabetes? That's the goal. In the US, that number actually is in the range of 60 to 80,000 people. So it turns out you're 10 times bigger in terms of your population, Ryan and BJ, but your incidence of type 1 diabetes is not quite as high as farther in northern hemisphere. So it turns out it's about 60 to 80,000 per year is what's estimated. And when people get type 1 diabetes, there's too much diabetic ketoacidosis, like in kids primarily. It was like 1 in 3 kids would get DKA when they were diagnosed with type 1 diabetes and have to be hospitalized with it. But during the pandemic, it went way up to over half. And so this is an important thing that we need to reduce. And finally, type 1 diabetes has genetic and environmental contributors. They both of those things. But let me actually ask you, you don't have to answer all, whatever, 39 of you at once or at all out loud, but think to yourself, or maybe I'll ask BJ or Ryan or Victoria, is the cause of type 1 diabetes known? Since you introduced BJ, I'm allowed to harass you. So is the cause of type 1 diabetes known? Yes or no? Or Ryan, if you want to answer, I just saw your videos.
Um, I believe it's no, but I'm a dumb American, so could be wrong.
Jeez, that's terrible. Well, you're right. It is not known. Type 1 diabetes is what we call an idiopathic condition, meaning we don't know the cause. If you, Ryan, I don't know your last name, I'm sorry, but if you discovered the cause of type 1 diabetes, it would be called like Ryan's disease or something. When diseases have a name like type 1 or type A, it's because we don't know the cause. And that applies to type 1 diabetes. However, we know a lot about the steps that lead to the loss of insulin-producing cells, even if we don't know the first initiating cause. We know that someone needs to have some genetic predisposition, and we know there's environmental influences, even though we don't know the exact ones in particular. But let me tell you a bit about what we call the pathophysiology or the steps of insulin loss. We know a lot about those steps. We just don't know the inciting or the core cause. So somehow the beta cell, insulin-producing cell, gets damaged. And that may not be the starting cause. And if it is, we don't exactly know why. But there's a little bit of damage that's happening. And an immature, what's called an antigen-presenting cell, it's part of our adaptive immune system. These cells are going around looking for like viruses and stuff. Well, it sees these and it has a genetic predisposition to identify them as foreign. And it turns into a mature antigen-presenting cell that then goes to a naive T cell. T cells are like the soldiers of our immune system, and it activates them through this huge cascade that I won't go through that creates things called cytotoxic T cells. These are T cells that are designed now to attack the antigens that the mature antigen-presenting cell presented to its sort of like earlier versions. And so it'll now bind to those antigens to the beta cell and start destroying it. and it lets out all these inflammatory things. We call them cytokines and chemokines, which then draw in the innate immune system, which are all those immune cells that can come in and destroy this beta cell. And it could be that the initiating problem is this T regulatory cell. When we're in when we're fetuses, we put together a whole library of cells that just take account of what our own antigens are, so that when we're born, it keeps track of those so it can find new antigens, like from viruses or bacteria, to attack. But the ones for self-antigens, we have these regulatory cells that keeps our immune system from attacking those. And so it could be that that's the key problem, this tiny little abnormality in our immune systems that just allows this whole thing to attack our insulin producing cells. But regardless, there's this other cell called a B cell. They make antibodies. And these antibodies may not be causal, like they may not go and injure the insulin producing cell, but for sure they circulate in blood and they provide an opportunity for us to see that this process has started. And so it turns out there's these four specific antibodies. They're called GAD, IAA, IA2, or ZNT8. I can tell you what they all stand for, but don't worry. There's four specific antibodies, and there's a messy one that we don't measure as much anymore called ICA, or islet cell antibodies. But we can go and measure these antibodies in people, and if they have two or more positive antibodies, it's kind of a marker that it's a guarantee that they're going to go on to develop diabetes. Here's some example from some studies. There's a few studies where they took a whole bunch of people, they checked for antibodies. These are people without diabetes. And if they had two or more antibodies, you can see that over 20 years, it was basically a guarantee that they would develop clinical type 1 diabetes. And in some of those cohorts, they tested family members who don't have diabetes, so like your brothers and sisters and stuff. So they were family members. They're more likely to have positive or two or more positive antibodies if you have a family member. But whether you have two or more antibodies from a family with type 1 or from a general population of people who don't have family members, either way, if you have two or more antibodies, it's basically a guarantee in the next 20 years that you'll get type 1 diabetes. So that's a key discovery. And so what it does is it creates this opportunity. We now see type 1 diabetes differently. If you imagine, here's a little figure that shows like a normal islets or with the beta cells that produce insulin in them. It's normal, but maybe this person has a genetic predisposition and they're now going to start losing those beta cells. They have 100% of them here, and over time they're going to lose them such that they hit, we think, about 10 or 15%, where they can no longer control blood sugars or overproduction of ketones, and people become sick and have new onset type 1. We now call that stage 3 type 1 diabetes, where they've got symptoms, high sugars, the antibodies, and they need insulin. But there's these preclinical stages. Stage 1 is when that attack has started. There's 2 antibodies out of 4 or more, but blood sugars are perfectly normal. We call that stage 1. And we can test that blood sugar through random sugars or A1C or a thing called an oral glucose tolerance test, where you drink this grotesque syrup and see how high the sugar goes. These are ways we can identify that people have normal blood sugar. And then stage 2 would be if they have those 2 antibodies, but now they go on to progress to not have hyperglycemia, but have this sort of gray zone blood sugars that some people call dysglycemia, other people call prediabetes. They're kind of like not normal, but they're not high enough that you need to really do anything about it now. So we call that stage 2. And when someone's in stage 2, remember, if they're in stage 1, it's like 100%, almost 100% chance they'll get stage 3 type 1 diabetes in the next 20 years. But when it's stage 2, it's much higher in the next 5 years. It's sort of like an indication that you're more quickly on your way there. It turns out it's a 75% risk in the next 5 years. So that's called stage 2. And if someone's in stage 2, there are now therapies that interrupt. Remember that that antigen producing cell, and it had this T cell receptor. It interferes with that interaction to try and take away the immune reaction. in the islets and the beta cells. So I hope that makes sense. And stage 4, by the way, is when people have established clinical type 1. We think after about 3 or 4 months of diabetes, we don't think we have as much of an opportunity to interfere with the immune reaction. We think it's sort of established. But I don't know if I believe that that's true. I think that's a bit nearsighted because you know that some of you underwent a honeymoon phase, like you went off of insulin maybe a year or so after your diagnosis. So maybe we should be looking at that population to protect their insulin producing cells at that time. But right now in the research field, they say that once you've had 3 or 4 months of type 1 diabetes, you're committed to insulin. We're going to mostly research people in the first few months of onset or prior to the onset of stage 3. All right, I hope that all makes sense. I feel like I need to repeat this in some way, but maybe I'll just say very briefly what you've always thought of as type 1, we now call stage 3 type 1, where you need insulin, you're sick, your sugars are high, maybe you're in hospital or you're in a clinic. But there are these preclinical stages, stage 1, positive antibodies, stage 2, positive antibodies with slightly abnormal blood sugars that give us an opportunity now to intervene and try and prevent progression to clinical type 1. All right. So what's the most common age of type 1 diabetes diagnosis? I'm going to harass, or maybe people will enter it in the chat. Is it early childhood, adolescence, adulthood? Early childhood, says Sky. Oh, I just closed it, so I didn't hear the other one. Ryan, what do you think? Oh,
If
you're
I
muted.
if I can unmute myself, I'm gonna go with A, Bruce.
So you agree with Sky. Well, let's see who's right, or if you're right. Turns out type 1 diabetes, this is the incidence by age, and it's tough to see, but there's sort of like 3 little peaks. There's puberty, young adulthood, and then later when people are screened for type 2 diabetes, we pick up some type 1 diabetes. In fact, the 62% are over the age of 20. The median age is somewhere around 20. So childhood onset is just a small subset of all the type 1 diabetes that happens. But I'll tell you that most of this research has occurred in children and adolescents. We know if you have antibodies at that age, you have a 20-year risk, but I'm not sure if you're like my age and you're well into your 30s like I am. That's a lie. But if you have antibodies then that it's also a 20-year risk, but we're assuming that that's true. But these are how the antibodies occur by age. There seems to be a peak. Remember these 4 that I told you about? GAD, IAA, IA2, zinc transporter 8. They have a peak incidence at around the age of 2, but you can see they can occur at any age up to 14. And it's just that we've not studied many people beyond the age of 14. And so based on this, what they're suggesting that we start with people who are family members of those with type 1 diabetes, and they can get their first screen at the age of 2 or around the age of 2. But then if they're negative, they should be rescreened 2 more times between the age of 2 and 12 to 15. And so then if you get screened around 2 and then let's say around 7 and then around 12 and you have 0 antibodies out of 4, the assumption is that your type 1 risk is like the general population, which is a risk of only 0.35%. You can stop follow-up. But it's not really known that, let's say I see an adult who's 20 who doesn't have diabetes but has a family member. Do I just screen them once? If they're 0, then I assume they'll never develop them. We're not exactly sure about that, but that's the assumption for the moment. So why would we screen for type 1? Well, the first is that it's been shown really nicely. When you screen and identify risk, you actually do reduce diabetic ketoacidosis at diagnosis by about 90%. Just through basic education, what are symptoms of high sugar? Having a way of testing some occasional sugars, getting education about sick day management and diabetic ketoacidosis. If you're sick with anything, check some sugars and ketone. That really helps people who are at risk of type 1 prevent DKA. It also, to be honest, I've followed people with preclinical type 1. It looks like it allows a milder clinical onset. In other words, I'm seeing people and we decide when we start some insulin, and it might just be basal insulin for a few years. and then maybe it's basal insulin plus prandial insulin with their largest meal, like at dinner, for another few years, and then eventually maybe they're on full multiple daily injections or a pump. But it allows us to ease into that, gives them a better opportunity for psychological adjustment to all this, but also it helps us identify people for new therapies. And that's what I want to tell you about now is this therapy. So, but did I ask you this already? What approximate, sorry, I'm gonna definitely bug BJ on this one. So what approximate percentage of new type 1 cases occur in people with a family history of type 1?
My first guess would be 30%.
30%? Okay, I
Hmm.
need an answer from Ryan. I guess I don't need
Uh,
oh,
Sorry, tech
okay.
support's struggling to unmute himself. I'll go with B as well.
30%. Okay. Oh, but by the way, the last question, what was it again? The kind of typical age of onset. You and Sky both said early childhood. You were wrong. Turns out it's most people are adults when they're diagnosed. So that's a common misconception. It's just we know about kids. You folks who get together as teenagers and young adults, well, you all have diabetes at this stage. You haven't yet met the people who are gonna, from your generation, who are gonna get diabetes in their 20s, 30s, and 40s and beyond. Um, so the percentage of new type 1 cases in people with a family history is actually quite small. So the right now, ideally we would uh, screen the general population, but it's tough to implement screening in everyone with these antibodies and convince people they need it and that it's worth doing. So we're starting with people, relatives of people with clinical type 1, because they know about type 1 diabetes. If you're sitting on a bus and it shows you 10 posters that say get screened for these 10 different diseases, you're unlikely to volunteer to screen for something you've never heard of. But if it's in your family, you're more likely to want to know. Or if you have a child with type 1, you'd like to know if your other child is at risk or not. So this makes sense, but it's only, even though first degree relatives of those with type 1 have a 10 to 15-fold higher risk than the general population, it's only 1 in 10 people with type 1 that have a family history. Most people who develop type 1 do not know of any family member when they're diagnosed. You can think about that amongst yourselves for the moment. And by the way, I have diabetes. My kids have a much higher risk, 10 to 15-fold higher risk than the general population. But because the absolute population risk is so small, their risk is still very small. It goes up to about 5 or 6%. That's why most people with type 1 do not worry so much, when they're having kids, whether they're going to pass this on to their kids, because the magnitude of risk is pretty small, but much higher than the general population. But people with other autoimmune conditions like thyroid or celiac, rheumatologic conditions, autoimmune adrenal, it's called Addison's disease, or dermatologic conditions like psoriasis, they're at much higher risk similarly, although their absolute risk is pretty small, but they're at higher risk of type 1. And then there are these certain genetic variants, which I wasn't going to talk too much about, but turns out there's some simple tests we can do to see if we have a polygenic risk score, which gives us an idea if we have a genetic predisposition. It's fairly easy to do. It could be done on blood spots, like, for example, heel pricks at birth. So this may be something in research that we're going to move towards. It's kind of like a proxy for a family history. It's like finding all the people out there who don't have a family history, but if they have a higher genetic variant risk, that it's kind of like they do have a family history, and then they can undergo screening for antibodies. So how do we screen for antibodies? It turns out it can be done through blood draws, like a venous blood draw, or even on finger sticks with blot paper collection. And so in Canada, stuff's going on like this in the US too. But in Canada, Diane Werrett, who's the lead of TrialNet in Canada, a research network, she started this thing called CanScreen T1D, and they're looking at the general acceptability of general population screening. They're interviewing people, figuring out how acceptable this is. They're looking at bringing in antibody testing core labs into Canada, because currently we send most of them to the US, and also evaluating that polygenic risk score in heel prick samples from birth cohorts. So we're going to know more about this later, but right now, TrialNet is a way to get screened. You have to meet certain criteria, like you have to have a first degree relative or be younger with a second degree relative. And you shouldn't go into this without being interested in research generally. But that's a great way that I don't, I say trialnet.org to my patients all the time, like around having their kids screened or family members. And then in Canada, we have this kind of cool thing called Uncover T1D. So the company that's brought in this therapy, it's called Sanofi. They've sponsored a program where people can get through one of their healthcare practitioners, they can get either a finger stick test or a blood draw done through a local lab that can also be done at their home by the local lab sending a blood draw phlebotomist. And then we can get these at hospital labs as well. But there's a whole bunch of ways to get tested. I hope that was helpful. So let me give you a case, actually. This is someone that I saw a couple of years ago. He's 31 years old, and he had what we call stress hyperglycemia. He had these like awful kidney stones with like horrendous pain. He went with this horrendous pain episode to the emergency room, and it was dealt with. But he was found to have a blood glucose of 15, and he was sent for follow-up by an endocrinologist a few weeks later. And his sugars actually looked normal. His A1C looked really good. Actually, he had put a sensor on, and his time in range was nearly 100%. But he was found to have positive antibodies. So this guy was found to have he had two antibodies positive. He didn't have insulin resistance risk factors because usually when we pick up pre-diabetes, we're worried about type 2 diabetes. But in type 2, there's often a family member with type 2 diabetes, or someone has risk factors. They're getting certain medications like steroids, or they have overweight or obesity, or are very sedentary. There's often these risk factors. And also, he didn't have a family history or a personal history of autoimmune disease, but he definitely had these high antibodies. And I was tracking his A1C over time, and it was gradually increasing. It settled at 4.9 and it went back up to 5.8. And then last summer, when we knew that we would have a therapy available, I retested his antibodies to see if he still had two, and he did. They were the GAD antibody and the zinc transporter 8. They were very high. And his A1C had risen now from the 4s to 5s now to 6.4. And actually, prediabetes is defined in Canada as 6 to 6.4%. So he was on the verge of having actually a diabetes range. But he was wearing a sensor. There's no way I would have started him on insulin. He didn't have high enough sugars. His random plasma glucose was 8.3. So this is a situation. This is a real person who was found to have slightly high sugars, positive antibodies, and now the sugars were progressively getting higher. And now he's in what we call stage 2 because he has prediabetes blood sugars and 2 positive antibodies. So his risk of moving on to clinical disease needing insulin is really high. It's 75% in the next 5 years. This is a real situation that he's in. So I could just counsel him about and us wait and see when he develops diabetes and just give up and start insulin. Just like when you were diagnosed with diabetes, there might have been some phase where it looked like you were making some of your own insulin. Maybe you went into a honeymoon phase, but your team just gave up and they were like, well, we'll just wait until you need insulin. We'll start insulin. To me, it's a really aggravating, hopeless situation. And it really drives, for me, the desire for therapies that actually preserve insulin. So here's a figure where I'm showing you that pathophysiology or the steps in that immune reaction against the beta cell. But what these bubbles on top are all these names of different drugs that target specific parts of that immune reaction and prevent it. And there's a lot of interesting stuff here. There's more trials going on in stage 3, new onset type 1 diabetes, which I think would be magical. That moment that you're in the emergency room and you've got new onset type 1, don't you wish then that there was something that could help recover your insulin producing cells rather than going through this whole thing of trying to predict and find who's at risk and following them? That would be even better. So there's a lot of research in that area. I'll tell you that we're doing some studies in Canada with a drug called bimekizumab, which decreases the red area down here, all those inflammation cells that draw in the innate immune system. And there's also sites in Vancouver, Edmonton, Montreal. We'll be starting this study at the end of the summer. And Diane, who's leading TrialNet in Canada, they have two TrialNet studies, an anti-inflammatory called an interleukin-2 receptor antagonist, and it's called Reset T1D. And then there's another one that uses teplizumab in combination with another drug called antithymocyte globulin. And these are for kids and adults, actually, at either stage 2 or stage 3 type 1 diabetes. I've put my research coordinator's email address down there in case you know of anyone with new onset diabetes and within weeks or months. You can reach out to him and he can let you know what studies are happening around Canada. But out of all these therapies that are being tested, and I told you nothing about them, it's so interesting, but I could spend an hour about it. The one therapy that's made it to clinical practice so far is teplizumab. And so I want to tell you about it. It was through the TrialNet study group. They did a pathway to prevention where they took family members of people with type 1, tested for antibodies. Once they had 2 antibodies, they underwent metabolic monitoring with blood sugars over time. And once they got prediabetes, then they're eligible to be randomized into this trial. They were approached and they said, would you be interested? And there was about 76 people who said yes and were randomized. And the outcome here was time to the onset of stage 3 type 1. So I'm showing you here a thing called a Kaplan-Meier curve. It just shows you the two groups, the people who were randomized to teplizumab or to placebo. And they didn't know whether they were on teplizumab or placebo. They each got 14 on consecutive days intravenous infusions of a study drug that might have just been water or it might have been teplizumab. They didn't know, neither did the study investigators know. And the people who got water, within even the first weeks and months of follow-up, they were getting diabetes. So this line goes down. This is the proportion who are free of stage 3 type 1 diabetes. And you can see it's dropping over time. But the group that got teplizumab, you can see they were kind of protected. Now, they still went on to get stage 3 type 1 diabetes, but much slower, as you can see. Most of the protection looked like it was in the first year. This study had the risk reduction was about 60%. It's called a hazard rate ratio. So the reduction in the hazard or instantaneous risk of getting type 1 was like 60% lower. It means that they needed to treat about 4 people to prevent one new onset of type 1 over the next 2 years. So that's a really nice finding. And this study, even though it was an early phase study, because the findings were so strong, it went to approval by the FDA in the US and a whole bunch of other countries, including Canada last year, for use in people with stage 2 type 1 diabetes who are at least 8 years of age or over. But in the US, they've already approved down to age 2, and we think that's coming to Canada as well. There were side effects, though, with this drug. Most of them were just like little lab abnormalities, like it decreases the lymphocyte count temporarily over a few weeks, which is not a big deal. Lymphocytes we don't need around. It doesn't make us sick unless we chronically, like for many, many months or years, have low lymphocytes. Then we get what people with HIV have, like a risk of these infections, but not over a few weeks. The main thing is that when the drug is started, it can just briefly activate some of the T cells to put out some of those inflammatory things called cytokines, and it kind of can give us like a flu-like illness. Technically, it's like a thing called cytokine release syndrome, which we see in cancer therapies, which is really dangerous, but it's actually a very, very mild version that doesn't progress, but it can make people feel kind of flu-y, feverish, sort of malaise, weak, stuffy nose, this kind of stuff tends to go away after the first week. This is how it's given, actually. The full dose, it's based on someone's body surface area, like how tall they are. It's a calculation. And the first day they get 1/16, and then the second an eighth of the total dose, then a quarter, a half, and then the full dose on day 5 for the remaining 14 days. The infusions can be given at home or in outpatient clinics or in a hospital. Mostly the kids have been receiving them in hospital. For myself, we're doing it in an outpatient clinic. The rheumatologists give similar agents for people with rheumatologic diseases. So there are these clinics all over the place. There's one that used to be in our hospital that was kicked out across the street. And so I can have people infuse there and I can pop in on them each day to see how they're doing. And then on weekends, they get, or on holidays, because we need 14 consecutive days, including Saturday and Sunday, they have a home infusion nurse go to the house and see them. There's some practical issues. We give pre-medications with like acetaminophen, that's Tylenol, antihistamines, like Benadryl, and antiemetics or anti-nausea drugs like Gravol, although you don't have Gravol in the US, it's called something else. Or we can use Zofran, which is a prescription version, although actually Zofran in the US is not prescription. So either way, there are all these can all be over the counter that help decrease some of those sort of flu-like symptoms in the first week. And then we also do safety lab monitoring for their complete blood counts and their liver enzymes through the infusion on certain days, and then 1, 2, and 4 weeks afterwards. And after 4 weeks, we're no longer worried about any safety issues. We just go on to metabolic monitoring. So this person, it's recommended in stage 2 that someone simply have an A1C every 6 months. What I do is I ask people to either do finger stick or a sensor once every 6 months, and also an A1C every 6 months, but not together, but so that there's something every 3 months. So on this 3rd month, they do blood sugar monitoring, but 3 months later an A1C, then 3 months later blood sugar monitoring, then 3 months later A1C. So I have his sensors and his A1Cs, and you can see at baseline he had that A1C of 6.4. Actually, his estimated A1C was 6.5. You can see he was getting some high sugars occasionally, but they would come back down immediately. Like there's no way you would start such a person on insulin. It looked more like prediabetes. And then 3 months later, after the infusion, his estimated A1C came down a touch, basically a similar profile, although what he explained now is that he was able to eat much more generously. Like here, he was restricting carbs more, and here he could have pizzas and not worry about prolonged hyperglycemia. That's not the goal of the therapy. The goal is just to prevent the need for insulin, but it was interesting that we had that observation. And then 6 months later looked very similar. The estimated A1C was 6.4. His actual A1C was 6.3. And you can see, even though there were some high sugars occasionally, they weren't persistent, definitely no need for insulin. So we'll continue following him like this. And he's aware. He also has a ketone monitor in case he had prolonged high blood sugars. He could check to see if his ketones are high. Then we'd know he'd need to get on insulin right away. So that is this new era that we're entering around identifying people at risk of type 1 and instituting new therapies. Trust me, teplizumab is just the start. There's all these other therapies. Maybe they'll be stronger. Maybe they'll work well in combination with teplizumab. But this is an amazing thing as a diabetes practitioner for me to have to be able to help people at least delay the onset of type 1. So maybe I'll just take a few more minutes and tell you about cell-based therapies, and then I'll stop talking because I feel like I talked too long. I'll do this quickly and then we'll get into questions if that's okay. So you may know about islet transplantation. Basically, people who die and would have written on their donor card, on their licenses, for example, that they're willing to donate organs, could have a donated pancreas that then would get transported across the country to a lab that would digest this thing and pull out the insulin-producing cells into a purified islet pellet. And here's an image of an islet. And these islets, they're very fragile. They have this beautiful little supply of blood, but when they're pulled out of the pancreas, they lose that blood supply and they're very fragile. This is what it looks like. Here in Toronto, we have one of these labs, and I kind of went in with my iPhone and I was taking images. They're putting enzymes through this pieces of this pancreas to start breaking the tissue apart and then spin down and find all of these islets. It takes many, many hours to purify those islets. Then those islets are infused into the vein. It's called the portal or the hepatic vein, a vein that goes into the liver. And then these little groups of cells get stuck in the liver, but they get bathed in blood and they can survive there. Most people need 2 or 3 infusions of these to have any discernible effect. And most people who get these donated islets from donated pancreas, we call that allogenic donor, meaning from another person. Most people don't come off insulin. Most people are having this procedure because they're literally suffocating with too much hypoglycemia. Whatever way they're managing their diabetes, they're not able to prevent hypoglycemia. They're in the emergency room frequently. And by giving these cells, they make some insulin, even though they don't come off of insulin, but it makes the diabetes easier to manage so they're not having severe hypoglycemia. But insulin independence at 2 years is like 42%, and at 20 years is only 8%. That's from the Edmonton protocol that's been around for the longest time. But the problem is we don't have enough donor cells. And these cells, actually, I removed this, but they kind of die when they're infused because there's this immediate blood-mediated reaction. That's why they need multiple infusions. And because they're coming from another person, they need lifelong immunosuppression with drugs that aren't so bad to take, but they create risks of long-term infections and cancers. So for a lot of people with type 1 diabetes, in my practice, I would worry about them being on lifelong immunosuppression. So a solution, at least to the source of the cells, are stem cells. Turns out there's this guy, James Thompson, in the 90s who discovered that you could pull certain cells out of fertilized eggs, basically early embryos, and those cells have the potential to turn into whatever cell you want them to become. And a decade later, Shinya Yamanaka, this brilliant guy in Japan, figured out a way to take adult human cells, like from the skin or from the inside the mouth, and through this Yamanaka recipe, could guide them back to be a stem cell. And so now you could figure out how to take that stem cell through cocktails of recipes. Some of them are mentioned here. This is overly simplified, to guide them through all the steps to become a stem cell derived islet. And we've had these pancreatic progenitors and these islets that now could be grown in culture in a lab. And this guy, Doug Melton at Harvard, figured out a way to take those stem cells and guide them all the way. He took an embryonic stem cell and did this. And he started a company. Well, actually, he was a stem cell biologist, not working in diabetes. And then he had two kids who were both diagnosed with type 1, Sam and Emma, and he started Sema Therapeutics, and it was bought by this huge company called Vertex, and they've really pushed this forward. So Vertex, near the beginning of the pandemic, went ahead with a human trial, and this guy was the first to receive it, and he went to the media, like they wouldn't have asked him to, but he did. And he got just a partial dose, a safety dose, and he was insulin free for the rest of his life. So that was pretty amazing, but he was taking immunosuppression. And then in Canada, we took on this study. Our first patient was in 2023, and we brought a whole bunch of people. This is in collaboration with the lead of our islet program. His name's Trevor Reichman. It was really exciting. And our first patient, not that we encouraged her, but she went to the media as well, and there she is, and she's been insulin free as well. So this trial, so far, actually, they've now recruited over 50 people, but 12 people this past year had reached the 1 year mark from the infusion, so we could look at 1 year outcomes. And Trevor here in Toronto was the lead author on this paper in the New England. It took people with severe recurrent hypoglycemia who were otherwise quite healthy, and it eliminated the severe hypos. But here you can see their A1Cs came to target, like around 6%, like even below the target of 7, around 7 or below. And on top of that, most people came off of insulin. Not everyone. There were 2 people who were on much lower doses, but not quite off of it yet. You can see it doesn't work immediately. The cells take about 6 to 9 months to kick in and fully waken up and make insulin so that people can come off of insulin. So this would be a solution for the type 1 population with severe hypoglycemia, or because there you have to have the risk benefit. You have to have a good reason to accept being on lifelong immunosuppression and their side effects. So having severe hypoglycemia is a good risk benefit. But the other population that makes sense are those who are already on immune suppression. So for example, people with type 1 who've unfortunately had kidney failure, many have had kidney transplants, they're already on immunosuppression. Why not get these cells? So right now the trial They're moving towards what's called a registration trial for those with hypoglycemia. That's fully recruited. Now we're going to know as soon as over the next couple of years whether this can be used in the population with severe hypoglycemia. And they're starting a small study that will also register for people with kidney transplant. So honestly, within the next few years, we may be seeing this as a viable treatment for these two groups of people. But this isn't everyone. That's not all of us. Not all of us have severe hypoglycemia or kidney transplant. So what they're trying to do to avoid the immune suppression, they tried encapsulating these, and there's a bunch of things I could tell you, but it didn't really work. Let's just say that. But another method is to genetically modify these cells. It's using that CRISPR-Cas9 technology you might have heard of to change gene expressions in cells. And what they do is they get rid of these HLA markers, these human leukocyte antigen markers that draw in the immune system to the cells, and also put these blocking things called CD47 that decrease the immune system from touching these cells to protect them. And there was a proof of concept publication last year in the New England Journal where someone had these injected into their arm muscle. And the cells, they were very small amounts, but they survived very nicely and were making insulin. So this now is going into human trials. We think this year. This is a company called Sana, S-A-N-A, and it's extremely exciting. This could be the solution for all of us, but realize no human has gotten a full dose of these yet. And so we'll be learning about that this year. So I wanted to share that with you. I was just going to make a few random additions. You know, diabetic ketoacidosis is a big deal in type 1 diabetes. A lot of us are not really aware of it, and it's kind of complicated to manage on sick days. And my research group, we did these multiple steps of understanding DKA better and these huge trials and studies on predicting who gets it by measuring blood ketone levels. You know, like you're all supposed to have ketone testing equipment. And it always expires. But before it expires, you could use a few of these tests to see if you're at a higher distribution or risk of getting DKA. But we created, with about 80 people living with type 1, we co-created this sort of infographic that helps people understand what DKA is and how to kind of evaluate whether it's starting and feel confident about going to the emergency room if they need to. We learned a lot about the barriers that keep people from doing all these things, like feeling shame about going to an emergency room, like they failed. And this is a situation where you've certainly not failed. You're well within your rights and doing the right thing in a situation with very high sugars, feeling ill, and elevated ketones that are not improving. And what's going to really change all of this is the fact that certain companies like Abbott that makes the Libra, they've now created a continuous ketone sensor. It's actually their continuous glucose monitor that also measures ketones continuously. So we don't have to worry about telling you, oh, this is when you should test and not test, and this is how you should track. It'll always be happening in the background, and it can signal to you when there are dangerous times. So these are very cool kind of advancements. There's dozens of other things I could tell you about, but I'll kind of stop there. I'll just tell you about a few research studies in my lab. First of all, we collaborate with the stem cell islet group. There's Trevor Reichman there. And if you email islet program, any of you can, or your physicians, Andrea Norgate, she's a nurse practitioner working with that group. She'll let you know about trials. If you know of people interested in the clinical islet program, you can just reach out to her for trials or clinical islets. For us, we're going to be starting this new onset type 1 study to rescue insulin cells later this summer. We're currently doing an automated insulin delivery, people who are on commercial AID, but aren't quite meeting the targets, the 70% time in range. We're adding this ultra low dose of one of those adjunct drugs called a sodium glucose linked transporter inhibitor that looks really safe and appears to really improve time in range. So if you're interested in that, please reach out. And then we're also looking for people with kidney disease. They've got low kidney function below 60 and high urine protein. So you could reach out for any of these to my coordinator, Andre Orzag. And then we're also looking for people who've got diabetic neuropathy with bad pain. And we've got this very cool kind of new treatment for pain. And you can reach out either to Andre, my key coordinator, or Hoda, who's another. Her name is Hoda Gad. She has type 1 diabetes, and her last name is GAD, which is the prime antibody that you can get with type 1 diabetes. So I thought that was interesting. I'm glad she's joined our group. We do a whole bunch of other studies, but those were tracking people, and we've already recruited for them. So please spread the word about these. With that, I'm hoping you understand that type 1 can be identified before symptoms start. We don't have perfect processes for identifying everyone yet, but we're getting started. I hope you understand that there's these cool new treatments to delay type 1 diabetes. And I hope you have a sense about where the cell-based therapies, over all these decades, we're always told that this cure is 5 years away. Well, now I can sort of say for at least a subset of people, it certainly is likely to be 5 years away. But now it's your time to ask questions. So I will stop sharing there so I can see your faces. Did I overwhelm like I feel like I did talk too long, didn't I, BJ? Was that
I thought it was fantastic, and I'm just looking at some of the comments, and we do have a question for you in our group chat. So if anybody does have questions, and if you don't want to speak up, you're more than welcome to type them in. We do have a chat available, and I got a comment right here. Not too long. They want more. They want more from you, Bruce. It was an
okay?
excellent explanation. It was so clear and easy to understand. Thank you, Seth. And then Seth did want to know. Can you speak more about the Eledon trial and the potential for the general T1D population? Do you mind tackling that question for us first?
Yeah, the Eledon trial, it's a little bit, I hate to say this, it's a little bit of a misconception. Somehow in the media, it came out as the cure for type 1 diabetes. But what it is, it's a trial of one of the immunosuppressants that keeps the body from attacking transplanted islets that looks like it's a much better immunosuppressant. Safer, more effective, works really well, doesn't cause side effects. So if that trial, it just happens that that trial is being done in islet transplants, but it's also that drug is being used in solid transplants, you name it. It just looks like it may be the new immunosuppressant that's a better immunosuppressant. So I hope that made sense, but it's not like this drug cures type 1. It just allows us to now investigate which cells are going to help cure it. And it won't be a cure because you'll need that Eledon drug, the immunosuppressant, to keep, you'll have to take it for life. But so it's not a cure necessarily, but it may be a much safer way of doing transplants and having safer immunosuppression. I hope that makes sense.
Wonderful. Thank you, Bruce. And then I have another question from Gareth. Stage, and let me get right up there. People are chiming in. Stage one, two, three for T1D onset. How much time is each range for people, and how much variability is there in these times from person to person?
Yeah. So first thing is that we mostly know about this from kids and adolescents and some young adults who've been screened and then their follow-up. We've not really identified people in their 20s, 30s, and 40s. We've looked mostly at younger age. Um, Once you have stage 1, as you could see, like you can never say never and never say always, but it essentially looked like 100% will get clinical type 1 in 20 years. Most of them will go through stage 2 so that you'll be able to see that they're developing the slightly abnormal blood sugars or pre-diabetes blood sugar levels. But some have stage 1 and they're in between the monitoring, they suddenly get stage 3 diabetes and need insulin. But it turns out it looks like most people will go through stage 2. And all I can say is that once you're in stage 2, the after it's sort of like the way to express the risk is that 75% will have stage 3 diabetes in 5 years. So it's just a much more, once you're in stage 2, you're much closer to developing it. So it didn't exactly answer your question. It's not like this perfect prediction. It's kind of giving just categories of risk.
Awesome. Thank you. And then we do have some comments, just very interesting. Thank you. Great information. Thank you, Lisa. Mary Ann said such important work. Thank you. And then we have a question from Marianne. Are we constantly producing beta cells or are we born with a specific number? Great question, Marianne.
Yeah, Marianne, hello, by the way. Um, yes and no. So it looks like our capacity to make it's been understood for years that our capacity to make new cells is very, very low. Like we're kind of born with them and that's it. But this has been contested in recent years. It does look like there are ways that there can be some recovery. Um, so, it's let's just say it's somewhere in between there. Mostly we were born with most of the set of insulin producing cells, but there's some capacity to increase them at least a bit. Now, I will say that even people with long-standing type 1 diabetes over 50 years, many have remaining insulin producing cells. They're usually small amounts. When they have them, they tend to be doing better with their diabetes management. They're getting a little help from their own insulin producing cells. But we don't know whether those are cells that survive since they were born or whether at some phase they were a recovery of cells. We're not sure, but that's the best I can answer your question.
Wonderful. And then I do see, Marianne, do you have a question about that follow-up?
Well, yeah, I think it's interesting because I've had diabetes now for type 1 for 50 years in a few months. And I don't know.
Congratulations,
And
by the way.
thank you. And this is really like, thank you. I
Yeah,
don't know, like,
congratulations, actually.
but if
Yes.
you are doing well, am I still producing some cells? Like, how do I even get that checked?
You don't.
Yeah,
Uh,
I think so.
yeah, you don't. There are ways to do it. So, for example, we can, like in our studies of people long-standing type 1, we did like a first morning, what's called a C-peptide.
Mhm.
C-peptide, it stands for connecting peptide. You make this protein that's a long protein, but you have to cleave out a C-peptide or connecting peptide. And then you have the two chains of the insulin molecule. So every time you make an insulin, you make a C-peptide. And we can measure it with these very sensitive assays. The best test is to have you off your insulin, eat a meal, track blood tests in the hours afterwards, and look for the response in C-peptide. That's very complicated. We probably do people more harm than good if we were doing that.
Yeah, sounds like it.
But for me, what it just means is that as we look at people with new onset type 1 or even before the clinical onset of type 1, and we find stronger and stronger therapies that revive their insulin producing cells, when we find really strong ones, I think then we need to be considering using this in people with longer standing type 1, maybe those who are showing that they have some insulin production of their own. And maybe then we'll figure out ways to do that test I just talked about more efficiently. But that's down the line. First we have to take people with as many insulin producing cells as possible to see if we can save them. And then once we do a really great job of that, we can take people who have very few.
Yeah,
But Marion,
thank you.
every other autoimmune disease, they kind of wax and wane. Like, for example, rheumatoid arthritis, you
Yep.
get, attack of the immune system on your joints, you get inflammation and pain and maybe deformity. And then it's like settles for months or years. And then it happens again. And it may be the same with type 1 diabetes. We get these intermittent attacks. And in between, whatever remaining cells there are, they might be able to struggle and recover a little bit. But obviously, it would be too risky to come off insulin to see.
Oh, yeah.
Once you get type 1, you're on insulin for life, basically.
Yep.
You get one of these therapies when they work and if they fully work. But it's possible that some of us would be able to wean our insulin or something, but I guess we kind of do because we're all adjusting our insulin all the time. And let's say you go on an automated insulin delivery system
Generally. Yep.
that adapts over time, you might end up with lower doses some years and higher doses other years. Um, I hope that.
Yeah, it's fascinating stuff, but thank you.
Wonderful. And Bruce, I do have a few more questions for you. Thank you, Marianne. That was wonderful. And I'm looking at, we have a question from Barb, and this is wonderful. Should new parents, where one has T1D and a strong family history of T1D, be banking stem cells for their newborn?
That's a great question. And I'll be perfectly honest, I don't know exactly how to answer that. Um, because, but I will say this, that right now, um, okay. So you may have read that in there was a patient in China who they did not the embryonic stem cell, but a inducible pluripotent stem cell. That means a cell from themselves. So it would be like me going and they take my skin or inside my mouth, and then they turn that into a stem cell, and now they guide it into an insulin-producing cell. When I receive that, my body is designed to kill those cells. So I'm still going to kill them. I'll need immunosuppression. And that person that was reported in 2024 from China, she had a liver transplant by chance for totally different reasons and had type 1. So she was on immunosuppression and they used one of her cells to cure it. So now imagine that instead of taking my skin cell, you took a stem cell from my cord blood that my parents would have kept a few decades ago when I was born, and you could now make that into an insulin producing cell. You'd still be in the same situation where I would need immune suppression. And also, they can take stem cells from other people, and now we're seeing this possibility that you could alter their antigens so they're less likely to be attacked by the immune system. So I kind of feel there's going to be solutions available that aren't going to rely on us keeping cord blood. But for other reasons, blood cancers and stuff, there may be reason to. And if I'm being honest with you, like we did for our children who are now teenagers, but at some point along the road, we just ended it. We stopped the storage fee. I don't know what the right answer is because it's building hope on future therapies, but I think for type 1 diabetes that we're going to have the solution that's not going to require our own stem cells to manage them. But please remember, I hesitated so much answering because I don't know what the hell to say to that question.
You did a great job,
So
Bruce. You did a
just
fantastic
realize there isn't a clear answer. I'm sure no one can give you a clear answer. Ultimately, you have to look within your own feelings about this and decide whether you would keep such cells.
And then we do have a few more questions. Jordy, are there any studies looking at both islet cells therapies and treating autoimmunity at the same time?
Yes. So that's actually really an interesting
Or
question.
preventing autoimmunity, rather?
Oh, prevent. Okay, well, there's a few ways to look at this. Let's say I have new onset type 1 diabetes. You could be giving me therapies to try and preserve my own cells. But remember, I told you about people who got clinical islet transplants. The cells don't work that great. They need 2 or 3 infusions. They don't come off, they can come off insulin, but at 2 years and 20 years, very few are off insulin. Why not? Because what's happening there is the immune system is attacking those cells. We're using immunosuppressants, but there may be more specific ways to decrease the inflammation in those islets, like with drugs like teplizumab that I was talking about, or other agents that are more type 1 specific. It turns out the other, I mentioned the Ozempic-like drugs, GLP-1 medicines, they actually help promote survival of insulin-producing cells because that's why they work so nicely in type 2 diabetes. And there are studies of using those along with immune modulators in new onset type 1 diabetes as well. So I have a feeling at the end of the day, it'll be a combination of these approaches. And something like the Ozempic-like drugs are at least very safe. I mean, they're not perfect, but they're very safe compared to like a traditional immunosuppressant.
Wonderful. Thank you. And then we have Suzanne. She said, just said, I think I missed this, but what is the initial cause of the beta cells not working before you actually get type 1? Is this stress related at all? Great question, Suzanne.
Yeah, I was just looking at the list of names, and there's someone whose name I recognize, but I can't remember where from, and I got distracted. So you need to ask me the question again. I'm so
No,
sorry.
that is okay. It's okay. And I have this belief that if you have T1D, you also have a little ADHD. We have to have it to manage our T1D. If anyone else can agree
Yeah, I
with
wasn't
me.
distracted by my blood sugar, but I was distracted by a
Yeah.
name on the list that I could swear I know. Anyway, go on.
Yes. But what the question was from Suzanne, I think I missed this, but what is the initial cause of the beta cells not working before you actually get type 1? Is this stress related at all?
Um, Maybe. So, one of the points I was trying to make, not that it's that important, but that we do not know the cause of type 1 diabetes. We don't know the cause. We have to accept, we call it in medicine an idiopathic condition, just like type 2 diabetes. We know a lot about the processes, but we don't know the exact sequence of causes. So what I was showing you around that inflammatory reaction with all the T cells and stuff around the islets are processes that we understand where the islets get injured, but we don't know where it starts. It might have been some problem with the T regulatory cell that allows someone's immune system to attack one of their own antigens. It might be some little virus that just inflamed the beta cell a little bit years ago, and that started the process of the immune system now noticing those antigens and doing it. We actually don't know, and we have to accept that we don't know. But we know that we know a lot about the processes, regardless of where it started, so that we can start to uh, kind of suppress that whole process of islet cell loss and inflammation. Oh, BJ, you're on mute.
I am sorry. Thank you. I had to cough earlier, but I just wanted to share a comment from Cody. And thank you, Bruce, for that feedback. Awesome work. I want the extended special edition of this chat, which my understanding is, don't we have a cafe chat after this at 9 o'clock?
Oh, yeah. I don't know if I'm invited though. I think I should leave this for people to connect.
Yes. Wonderful. But feel free to speak with people in this group, Cody, after this as well. And we will be providing the slides, I believe, to the participants today as well. So you'll be getting this information to bring back with you. And then I have a question from Gareth for a correlated rheumatic issues, thyroid, celiac, etc. Is the reverse correlation also indicative to risk for development? And is this an active area of research?
Yeah, so I'm not sure I fully understood the question, but I think it's that one fact is that if you have an autoimmune condition, you're much more likely to get another. But
Yes.
please understand when I say much more, like for example, if you have Addison's disease, that's a condition of the adrenal gland not making the adrenal hormones like adrenaline as reliably. You've got like 30 or 40 times higher risk of having type 1 diabetes, but 30 or 40 times higher is still a pretty low lifetime risk. So they are definitely related. We see much higher relative risk, but the absolute risks are still very small. I'm sure there's someone on this call who has type 1 diabetes and thyroid disease and Addison's or adrenal disease. I'm sure that person is here, but trust me, it's not more than one of you, or maybe two, probably one or zero. It's still pretty uncommon. But if you take someone with those conditions, they're at much higher risk than the general population for type 1 diabetes. So let's put it this way. If you think of autoimmune conditions, probably let's say one hypothesis is that the problem is with the T regulatory cells. There's some little hit that for some reason, the cells in our body, that library of T cells that are meant to suppress our own immune system from attacking self-antigens, for some reason, they just allow the body to do that, to attack our own antigens. And for some reason, endocrine cells are a prime target. So just imagine if that little aspect of our immune system, like the immune system otherwise works perfectly fine. We fight bacteria, et cetera, and viruses, but we're just a little permissive in allowing the body to attack self-antigens. You can see how if that's happening, there's no reason why it should be perfectly specific to one cell, like an insulin-producing cell. There may be dysregulation of thyroid cells or adrenal cells or cells in the small bowel that can lead to celiac disease and others. That's the way I see it.
Wonderful. Wonderful. Thank you, Bruce. And also, there was a link provided to the cafe session after this where we can speak with our other T1D friends and colleagues from this session. And then we also have some thank yous going out and a question from Seth. Is there any development of an AID that includes glucagon or other molecule to raise blood sugar?
Yeah, Seth, actually, I'm really glad you asked that because I'm just remembering something else that I'll bring up in a second. But yes, so you may have heard of, there's a company called Beta Bionics. They came out of Boston University and Harvard, Mass General. They developed what's called a dual hormone pump. It's a pump that has a chamber that delivers insulin and another chamber that delivers glucagon. And in fact, in my lab, we even did research with these dual hormone pumps. What we did is we kind of just configured it so you wore two different pumps, one with glucagon. One of the problems is that back in the day, we didn't have a glucagon that lasted in solution for more than a day, because you might know glucagon, you either have to mix the powder or spray the powder up your nose. It doesn't stay in solution very long, but they've developed more stable versions. Dasiglucagon as an example. So that problem is being overcome. So you could put in a glucagon cartridge and it lasts for days or a week, as opposed to having to change that every day. But with the FDA in the US, where this company submitted to, they said, listen, first you have to prove to us that you can make a single hormone pump and launch it into society and it be safe and effective. And so in the US, like Ryan or BJ could be on this, it's called the islet, made by Beta Bionics, and it's a single hormone. And they made it's kind of meant to take, like it doesn't, it's, oh my gosh, I don't even know how to say this properly, but it's kind of meant for the population of type 1 who's not really all over all of their diabetes, that it's meant to take people from these sugars to a reasonable level.
Yes, they
But
want the
that's-
A1C level to be 7% with the islet. It's one of those things that's for people who are looking to just maintain a 7 with a lot
Yeah,
less
but
work.
7 is perfect. That's the
Yeah,
goal, 7 or
yeah.
below. But let's just say overall, like, I really like it. Like it's simplified. It doesn't, they're like, oh, just not worry about carb counting as much and just tell me is this a typical meal or what? And it's a really good approach. But their next level will be able to have a bit more aggressive insulin algorithm, but have this backup of subcutaneous glucagon. Because it turns out when you give microdoses of glucagon under the skin, they actually do pretty well at bringing the blood sugar up. And so it will have this insulin adjustment algorithm. And then when that's not working, this little glucagon delivery algorithm. But those studies are happening now. They are presenting them to the FDA. So I think that is something that we'll see reasonably soon. But let me just tell you that back in the day, so we're talking like a decade or more ago, like we kind of left the dual hormone field just because it really looked like we could do so well with insulin adjustment alone, and the value add and the complexity of glucagon was too much. But now I think it's going to be feasible. But Seth, I need to say another thing. If any of you are interested in this study, it turns out, so I don't know if any of you know Mike Riddell. Mike Riddell, he's like this famous diabetes researcher. He's at York University here in Toronto. His background is kinesiology. He has a lab, a physiology lab, studies animals, but he also does clinical studies. He worked with the last graduate student of Charles Best, that Banting and Best person, whose name is Mladen Vranic, who unfortunately died during the pandemic. But in his lab, he was here at U of T, developed this area of therapy called somatostatin receptor antagonism. Basically, it's like a drug that you inject once a day, and Mike has studied it and has now brought it to a commercial company. What it is, the idea is that we have glucagon producing cells because our immune system attacked our insulin producing cells. And sure, our glucagon got injured because they're nearby, but they're still there. It's just that they're kind of put to sleep because we don't have normal insulin cells next to them, or we're taking all this extra insulin floating in our blood. It kind of puts them to sleep. What this drug does, is it brings them back to life, but specifically when the sugar is approaching low. So, for example, if we made your glucagon high, or if I made my glucagon high all the time, my sugars would just be higher all the time. What I want is the glucagon to occur only when I'm being stimulated with hypoglycemia. And so there's this drug, it's a company, it's called Zucara, and the drug is an injection taken once a day. And it's currently in what we call phase 2 or early studies. And we're doing this here, and there's a bunch of sites in Canada. So you could reach out to andre.orjag at uhn.ca, my coordinator, and he can let you know about that as well. It's for people who are having, in the last month, at least 1% time below very low range. So if you ever look at your AGP or ambulatory glucose profile tracings, you see the summary page. It'll show you your time below range, below 3. We're hoping mostly that we're less than 4%. And then the time below very low, which is below 3, we're hoping that we're under 1%. So if you're hitting 1 or more percent of that, then you're getting enough significant hypoglycemia for it to be worth to see in a trial whether this drug helps reverse that. And I totally forgot to put that. I thought that slide where I was talking about, I felt like I was promoting my studies too much, and I thought there was too much, and then I forgot about this one, but I should have mentioned it.
We love hearing about these trials as a T1D of 31 years. Our endocrinologists and our healthcare teams don't often let us know of such wonderful information, Bruce. So I'm sure not just myself, but all of us appreciate you sharing that. And just going back to the comments, I just wanted to share too that our wonderful IT team has included the links as well about the Beta Bionic pump, so you can get some information there. And then
Oh,
we heard from Lisa, who just shared she's also been diagnosed with several different autoimmune diseases, like many of us have. And I'm so sorry to hear that, Lisa. And going back to Jordy, we have a message from Jordy asking, does microdosing with glucagon reduce the issue of insulin resistance that seems to follow a glucagon injection for days? Or was that just me? And just sharing a little bit, Jordy, I know exactly what you're talking about. I've taken glucagon once and I try so hard to never ever have to take it again because the recovery was quite a long
it can be
process. So,
tough.
Bruce, do you
Yeah.
mind chiming in on that?
Well, when you have severe hypoglycemia and you need a treatment dose, you just have to accept. You get a whole flood of glucagon, and it might be tough to control sugars, but it's worth it to prevent that severe hypo. You would never plan on a microdose of glucagon when you're having a severe low. The concept with the microdosing in the pump is that if you're coming towards low and it's predicting that even if it fully stops the insulin that you'll continue to drop, then you might as well use microdoses to help prevent that. But if you had a severe low where you couldn't treat it yourself, someone couldn't give you glucose, then you'd need to get a full flood of glucagon, which causes insulin resistance. That's part of the point. It basically allows the liver to drain out whatever sugar it has in it to save you from a severe hypo. Now, maybe on the research front, and actually this is coming towards practice, is microdosing with glucagon pens, giving microdoses for things like exercise. Like, wouldn't it be nice rather than having to eat through exercise to take microdoses of glucagon? And I do work with some athletes and competitive athletes, and we've gone down this route off label. But this will be something we believe, because there's been a lot of research and there's a company behind it, that in the US, this is something that maybe in the near future, that we kind of have this little ability to take a little boost of glucagon before we go running, rather than having to plan all the, oh, I gotta put my activity mode on my pump an hour and a half before and take some extra carbs at the start and throughout. This would be another option for us to get through physical activity.
And Jordy did actually want to follow up with that question. They said yes. I was thinking though of the pump option, if that would cause the resistance or not. So what my understanding is, and please correct me if I'm wrong, Jordy, is that if a pump gave us glucagon corrections, would we still have that resistance or not with it being readily available like that?
Oh, I see. Would it cause a problem? Like taking little doses, will you still get that tough, like hyperglycemia following?
Yes.
No, I don't think so. And having done studies using glucagon, I can say that the microdosing, we're talking about like 1/100ths to 1/500ths of a treatment dose, but given repeatedly. So the amount of glucagon ends up being very little, just enough to help the sugar drift up without really overshooting. But again, anything's possible, and um, that could be a risk, but the intention is really good to really help prevent hypoglycemia even more. It's just that we've done such a great job with insulin alone systems now with preventing hypo.
Thank you, Bruce. And then just a few more questions. Alicia is asking if someone can reshare the email address for your coordinator.
Yeah, I'll put it in the chat right now.
Oh, you're the absolute best, Bruce. Thank you. And Jordy says thank you. And Marianne, I really appreciate this comment. I've done a couple marathons myself, and after my glucagon experience, Marianne just stated if uh, I did a study of microdosing glucagon during exercise with Mike Rydell, I'd rather use dextrose.
Oh, is that
Never, you
right?
can't go wrong with
Yeah,
good,
because
reliable
he
dextrose.
has done microdose studies. Ah, I'd be so interested to hear. I'll just say I actually believe that for the competitive athletes that I've done this with, it was more of a confidence thing. Like just having, they just need to know they're going to go in the competition with a few backup plans if in the moments before a race or whatever, they need something else. But I was never convinced that I know that it's the
But you got
perfect.
to run with all that stuff with you. It's more stuff you have to run with.
Sure,
Yeah.
more stuff to carry and be concerned about. Yeah, everything, every time we add it, and I've in my research has just been so much around the add-on or adjunct to insulin drugs that I feel like in many way can be amazing, but it adds another element. Everything we add, whether I think it's little or not, adds complexity. You're absolutely right, Marianne. But I will tell you that in my research, one of my guiding principles is that I feel like we're all kind of different. We're all unique. We all deserve as many choices as possible. Someone might say, this year I'm on an automated algorithm, but next year I want to be on this. And as long as I'm meeting my targets, and then when I'm not, then I want other choices. And I just feel like we all deserve choices to make that it's not like, oh my God, the only thing you can do is MDI and that's that. Just figure it out, make it work, get on with it, stop complaining. I would rather be able to offer people multiple options.
Wonderful. And thank you so much, Bruce. And I'm just going to do another shout out and say thank you to everybody for the questions, the comments. He did provide that email address that was requested. So please feel free to check the comments. And does anyone else have any questions? We are looking at it's 9:02 over here at least on the East Coast of Maine, where I'm at. And I just didn't know if anybody else wanted any questions for Bruce before we join each other in the cafe and have a rest of our wonderful night. A lot of thank yous coming out, Bruce. Wonderful presentation.
Thank you all. Like, I'm so impressed with how engaged everyone is. And it's amazing to see Connected in Motion doing so amazingly well. Congrats to all of you.
Yeah, we couldn't do it without all of you. So thank you again.
All right. Good
Okay.
night. It was such a pleasure.
All right. And
Thanks,
everybody have a good
Bruce.
night.